Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Bill Barr on with us tonight. Dr. Barr is a board-certified clinical neuropsychologist and the Director of Neuropsychology in the Department of Neurology at the NYU-Langone Medical Center. He is an associate professor of neurology and psychiatry at the NYU School of Medicine. He has served on the advisory boards of many professional organizations and is the past president of the Society for Clinical Neuropsychology, Division 40 of the American Psychological Association. Dr. Barr has been involved in both clinical and research approaches to sport concussion since the early 1990s. Talk about an early adopter here, folks. He has served as the neuropsychological consultant to a number of high schools and colleges in the metropolitan New York region and to professional sports teams, including the New York Jets and New York Islanders. He has conducted research studies on athletes at the high school, collegiate, and professional levels. His work has focused on the methodological applications of neuropsychological assessment in the athlete population and continues to serve as a consultant to many ongoing studies of athletes at all levels of competition. Bill, welcome to the Concussion Corner podcast.
Oh, thank you for having me.
No problem, Bill. So I know that, we've had some interesting things going on in the news lately with a blood test being released, allegedly for concussion, and we'll talk about what that means and what that is and what that isn't in this podcast. But with every podcast, I always start with, starting with your why. So I would love if you can kind of just introduce yourself a little bit and kind of start with why and how you kind of ended up in neuropsychology and how that led to your work in concussion.
All right. So from high school on, I had interest in psychology, but I also had competing interests in the sciences, and I thought at the time those would be competing interests. So by the time I got to college, I had it in my mind that I was going to discover the molecular basis of thought or something like that. But what happened at that point is that I got more and more into psychology, psychological theory. And I went more in the direction of studying to be more of a psychotherapist, psychoanalyst, and such, and kind of got derailed from that. And I came to New York in 1979 to go to graduate school at the New School for Social Research. And I was starting to study psychoanalysis there, but then I took a course in neuropsychology. And at that point, I said, wow, there really is something I can do to learn more about the physical basis of thought and everything. And I really started veering more in that direction, and that's where my specialty went.
Oh, that's tremendous. And I think we've kind of had similar trajectories where I knew I wanted to go into medicine myself. And I said, well, I'd like to go be a doctor of something, right? And then I said, well, I don't really, want to prescribe medication or get caught up in that. So what can I do? And physical therapy was just, spot on for me. So I love to hear that story.
Yeah.
I was wondering if we've had Dr. Erin Reynolds on here down at in Frisco, Texas. She works with the Dallas Cowboys down there, and athletes that have lived with concussion or dealing with concussion. She was trained at UPMC. I was wondering if you can let the world in too. We have clinicians from all over the world, from Australia to Singapore to the United States and everything in between, listening in. And I was just wondering if you can just let them know what a neuropsychologist is and what your role is in concussion management.
Sure. So when people think of a psychologist, the prototypic, at least clinical psychologist, is more of a psychotherapist in that. And then, as I mentioned, that's the direction I thought I was heading at one point. A clinical neuropsychologist is a psychologist with specialty training in assessment and treatment of brain disorders. These brain disorders can be from neurologic conditions or psychiatric conditions, but anything that affects the brain. So in terms of experimental neuropsychologists, they have various ways that they study brain functioning through tests, through electrophysiology, through brain imaging. And then clinical neuropsychologists are individuals that apply this science to the assessment and treatment of individuals, of people that come to the office. Mm-hmm. And through that, we perform studies on multiple individuals who come to our office and undergo these testing procedures so that we can perform clinical research studies and study the sensitivity of our methods, the validity of our methods, how effective they are, and such.
Wonderful. And, you guys, with PhDs and PsyDs, are traditionally trained in publication. Is that correct?
That's right. A PhD is a little different than an MD in that it is a research degree. So while MDs might be getting courses in biochemistry and those kinds of things, the PhDs are getting courses in research methods and statistics in addition to the basic sciences that they're studying. In our case, it's psychology.
Indeed. And just so our listeners know that it was actually in 1989 that a sports neuropsychologist, Jeffery Barth, is he still practicing, Bill?
He's retired, but I think he has some legal cases that he sees and such. But he's retired from his job at University of Virginia. But clearly a pioneer, highly respected guy in our field.
Indeed. And, for our listeners, that was the first, I think, publication, and correct me if I'm wrong there, Bill, with the SLAM model, coinciding or correlating both sport and concussion and some, cognitive delay and slowing there. I was wondering if you can let the listeners in just a little bit on, what historically that was and how that played out.
Sure. As I've seen him lecture on the topic and background on it. So really what it was is that at that time, people were starting to study concussion in mild traumatic brain injury. And what he was noticing that there were all sorts of complicated factors, and how can you really study this in a controlled environment? And the idea was to study who are the individuals that voluntarily go through these types of injuries, and athletes were the group that came up. So they decided that they would get prospective information using good research, sound research design methods, getting information on a number of athletes before the season and following them through having concussions and really tallying up how many concussions are there, what are the effects, and those things. And it was really the first controlled study, first controlled prospective study, meaning where you have data to begin with and follow the condition through its course.
Indeed. And, just for our listeners to know, the NCAA and Department of Defense in 2014 put together a Prospective, the world's first, I think we can call it like this, and, correct me if I'm wrong there, Bill, prospective study on concussion with tens of thousands of athletes and active service members that are serving in our armed forces. And, we really have to connect to where that kind of thought process came from. And that really was, that 1989 SLAM study with Jeffery Barth. And that's really, I think, where the future of a lot of our concussion research and data will be deriving from, is from these tens of thousands of N with a control for these service members and athletes in our NCAA cohorts.
That's correct. It's, in my mind, it's the safest way for us to get information on concussion and validating any new measures is to go through that prospective case control design.
Mm-hmm. Indeed. And, I know you are a man of good science and good data, and that is something that I know you live by. I would love to, because this is so a hot topic right now, in the last 24 hours, this has come out in the news, and, really everyone has reported, and really good reporters have reported this, and then it kind of took off like wildfire. But everything from New York Times to CNN, Chicago Tribune, Wall Street Journal, and so on has actually reported that the FDA has approved the first blood test for concussion. I was wondering if you could comment on that, and we're going to kind of debunk this a little bit for the listener. So I hope you guys that are listening in, either at the gym or driving to work or anywhere in between, kind of lean in here, because we really need to have a good discussion here about what's been going on lately in the press.
Yeah. Okay. So this idea of having a test for concussion is a desired thing, but it's not as easy as it sounds. Concussion is a clinical diagnosis, and really it's a combination of the injured individual reporting symptoms, the trained examiner identifying symptoms, and having it all meet together and making some sense with what we know about concussion. And so the idea of to have a separate blood test or marker that is independent of what the athlete has to state in terms of their symptoms, what the observer has to see, is really a good idea. So what happens is that people are trying to look and see, are there blood tests, are there tests from the cerebrospinal fluid or through imaging that we could use for this? In this case, this is a case where the blood test, in order to be approved by the FDA has, when they are defining concussion for FDA approval, they typically ask the test makers to use an objective measure, and positive CAT scan is one of the only objective measures that's out there.
Correct.
And we know that positive CAT scan is not a measure of concussion. There are plenty of concussions that have negative CAT scans. But
in fact, most of them, right? Most concussions will have a negative CAT scan.
That's right. So what the FDA, in fairness, has to use something as a standard, but what they use is a standard that is seen very rarely in the concussion world. So in the end, what it comes out is that what the test actually measures or is sensitive to is CAT scan positive mild traumatic brain injury. That is a subset of concussion, subset of mild traumatic brain injury, but it misses the vast majority of injured individuals.
Indeed. And essentially, to break that down, it's really looking for intracranial lesions. And that's very important. And said test results can be available within 3 to 4 hours, which is very comparable to what our emergency physicians and nurse practitioners and PAs are doing in the emergency department anyway, because what will happen realistically is that you'll be put on observation. With a CT scan, and chime in here anytime, Bill, with a CT scan, it's essentially like a really big magnifying glass, looking into your body, right? Or a very detailed X-ray with much more radioactive activity than an X-ray as well. I think 100 times that. So something to connect to is that with a concussion, you're looking at a neurometabolic cascade. And when I teach and I speak publicly, something that I say that most people can kind of relate to is hey, have you ever thrown salt water on a microchip? Or if you can think of dropping your phone into the toilet, because most people can relate to that, or dropping your phone into salt water like the ocean. Again, if I take a picture or an X-ray of my phone that gets dropped into both of those, bodies of water, again, structurally, it's going to look normal. But again, we've shorted out some circuitry, which essentially is what's happening with concussion. So again, we can't actually take a CT or an image of our brain to diagnose a concussion because we don't have the technology yet. I think we'll get there eventually with fMRIs and other things that are coming down the pipe. But again, anything that's out there is really for research purposes only. Thoughts there, Bill?
Yeah, no, I agree. And so it's really the struggle is having these go from experimental measures where you study them in groups of individuals and then taking it back and using it for an individual. That's where the issue is. Now, in fairness, that's what they did with this study. But like I said, that the criterion that they use are a very conservative criteria, and it's only met in a small subset of injured individuals.
Indeed. And, just for our listeners that are primarily healthcare providers and who this podcast is geared towards, we have to remember that we also have the Canadian CT head rule, which we're using on the sideline, and we're using, should be in the emergency department or urgent care centers, or if you're a direct access physical therapist or physician that's, evaluating a patient with a comprehensive physical targeted exam post-head injury, we should be using the Canadian CT head rule. And what we know factually in the last, 5 to 10 years since this has been out, we know there are some limitations. The original study was a single center study, and that actually this study actually has not affected physician practice in ordering CT scans. So we have this rule, but it hasn't really changed the behavior. So a lot of folks that are coming in with MTBI or concussion, because right now in 2018 those words are synonymous, it really hasn't changed the behavior of physicians. But just to keep in mind that Canadian CT head rule actually has 100% sensitivity for clinically significant injuries and injuries requiring neurosurgical intervention. Now, from a specificity standpoint, we're looking at 28.2 to 66.7%, but our sensitivity is great with the Canadian CT head rule. And just so folks are aware, that decision aid, and I don't really like to use the word rule, I like to either use the word guideline or decision aid. It's a Glasgow coma scale of 13 to 15 with a witness loss of consciousness, confusion, or amnesia with a closed head injury. And then recommendations for head CT are the following: greater than or equal to 2 episodes of vomiting, older than 65 years old, suspected open or depressed skull fracture, sign of basilar skull fracture, retrograde amnesia to the event greater than or equal to 30 minutes. And please be mindful that we often get confused with retrograde amnesia and loss of consciousness, so make sure when you're taking your history that you can delineate between the two. And a dangerous mechanism like pedestrian versus motor vehicle, occupant ejected from a motor vehicle, or fall greater than 3 feet or greater than 5 stairs. So again, we have other things out there. A blood test is going to be wonderful to rule out cranial hemorrhage, intracranial hemorrhage, but remember that is not a concussion. So once you start getting into talking about brain bleeds, again, not concussion. So thank you for your attention there, Bill.
Oh, no, that's great.
So anyway, yeah, and I think, you've been in a few newspaper articles and press pieces about like the wild west of concussion. I mean, you really are a early adopter into this world and a thought leader in the world of concussion, and it really is an honor to have you on this podcast, and I hope our listeners are leaning in and listening deeply. What have you seen historically since you kind of entreed into this world, with how the press has treated the word concussion and kind of where we are in the last 5 years?
Yeah. Well, I like to lecture about that. I have a slide that has my experience over the years. So when I started doing this work in the 1990s, we were actively trying to convince the players, the coaches, and the parents that we needed to take a look at concussion, be serious about it, have ways to assess it, because they wanted to sweep it under the rug. And one thing is we did a pretty good job of bringing it to everybody's attention. Mm-hmm. Then what happened so that was the 1990s. Then what happened was there was a lot of controversies about what are the causes of prolonged symptoms. But the real controversies came with the NFL stuff, with the emergence of studies of CTE. Some issues with the NFL being accused of covering things up, and the media caught attention to this, and it caught everybody's eye, and it really became a hot topic in the press. Mm-hmm. Now I think we're at the stage where we have to slow things down because the media got ahead of the science, mm-hmm. and the stories about the severity of concussion, the prevalence, and all these things, in my mind, have gotten overblown a little bit. And we got to step back and look at the studies. A lot of the studies are in their early stages. Even the CTE studies are and when you think about the science and disease and all that kind of stuff, the studies are very early in their evolution. And let's wait to get harder findings before making such changes in public policy.
Indeed. And, I just had a great conversation with Willie Stewart over in Scotland for this podcast as well. And one of the central themes, and we I think politely and appropriately disagreed, because you guys are really men of science and producing literature based off of very hard facts from what you're doing in the lab and in your research. My stance for that was, we've kind of seen this with pitch count, right? So with Tommy John elbow and pitchers in baseball. And what we've seen is that if you actually change some of the rules and legislation, you can actually, prevent some injuries that are really, could be lifelong devastating injuries to people. I think for most folks, we can kind of agree here that, bashing young children in the head repetitively is probably not a good idea. Or were you on that stance?
Of course, and that goes without saying. It's um, yeah,
Yeah.
but that's different than banning sports and tackling and other things altogether. That's my point.
Absolutely, absolutely, and I think that's where the middle ground needs to live, right? And again, I would love to hear your thoughts here. So, we have 2/3 of our children in both the UK and the United States are either obese or overweight. So that means folks are not getting out there, not playing in playgrounds. Or I was just in Texas, and the obesity epidemic is rampant down there. If you go in Houston, every third corner you see a gastric bypass advertisement on the side of the road. So again, I was at a park with my friends' kids, and just seeing that, I'm like, wow, there's only fit people at these parks, but we know that the majority of this population down here is obese. So where are these kids playing, and what are they doing? So as a physical therapist, I encourage movement all the time. Of course, it's kind of what's ingrained into me. But there has to be some kind of happy medium. What do you see for the future in the next 5 to 10 years of potential policy changes, based off some of the research that's coming out?
Well, I think we're already seeing a decrease in some of the sports like football. I
Mm-hmm.
think one thing that might happen is increasing popularity of other sports, even though some are contact sports like soccer. I think we're going to see a lot more going there, and I think we're going to see over the years the U.S. becoming more and more of a world power in soccer, as more of its good athletes are going in that direction, away from football and other sports. Um, that's one main thing I'm seeing, and then I think really the issue of some rule changes and really finding the happy medium
Mm-hmm.
in sports like football. I think some of the rule changes have been great in terms of the kickoffs and other things, and decreasing injuries and the spearing rules or the targeting and rules and all that. I think we still have a ways to go, but we got to find that happy medium. People don't want to take the hitting part out of these games, and
Mm-hmm.
I'm not 100% sure we should.
Indeed. And I don't only talk about football, because there's so many other sports out there, like cheerleading and actual amateur horseback riding, I believe, has a 500 time rate internationally than NFL football players in concussion. So
Exactly. Rates of participants, almost everybody that participates in that sport gets a concussion.
indeed. So this conversation is much more than football. It's really about just safe movement and having folks accessible to good quality care. Jeff Kutcher has already been on this show. He was the first 2 episodes that I launched with, really because he started that first sports neurology fellowship, and he, I think, pitched to the AAN in the early 2000s. This is 2015 was the first formal didactic year that neurology, our brain physicians, had training in concussion. So if they're not a young neurologist, they didn't have any kind of formal training in concussion. And even for myself as physical therapist, my entry level education in 2006 was one paragraph in a 1,500 plus page neurological rehabilitation book. So this is definitely a post-professional education journey. You have to be passionate about it. Dr. Aaron Reynolds, your neuropsychology counterpart, talked about that as well. What are you seeing in terms of consistent inconsistencies out there in the healthcare world, for folks that are seeking care that may be, being misled by folks that just are very Dunning-Kruger-esque or unskilled and unaware?
Yeah, it's unfortunate, and one of the things that's been eye-opening to me is dealing with a lot of my healthcare colleagues that so many are basing their views of concussion and its management on the media as opposed to the science and the journals, which
Indeed.
is shocking to me. And anytime I go to a cocktail party and meet a pediatrician, some of the things I hear, I go, yeah, but the research shows that doesn't work. Things like rest,
Mm-hmm.
prolonged rest, those kinds of things. I'm shocked what I'm hearing, and it's concerning to me where people are getting their post-professional education.
Well, indeed, and you're publishing this work, and quite frankly, the work that you're producing, really, that's some work with JAMA and other main big league hitters in the medical journal world, we're looking at 14 to 17 years from a knowledge translation standpoint to clinical practice. So once that paper is produced in the White Tower, it's taking at least a decade to trickle down effect. So quite frankly, I still have folks in the media reaching out to me that have like 2008 guidelines where you rest until your symptoms completely abate, which we now know is completely incorrect. We've just called this injury in 2017 a rehabilitative injury based off international consensus in Berlin. And 2012 was our first year that we actually included the neck, which is, in my world of physical therapy, one of our number one things that we're trained in is that upper cervical spine and cervical spine. And we just started correlating that to head injury and brain injury. So it's really quite amazing, what has essentially happened in the last 5 years. It's kind of exponentially grown.
So we've certainly done a lot and covered a lot of ground, but we still have a long ways to go.
Indeed. And, we have about 5 minutes left here. Where do you hope to see the concussion research and some of the legislation kind of move forward in the next 5 years?
Well, I think in terms of legislation, I think it's really, we've got to confront what we want to do about things like youth sports. But one thing I'd really like to see is to have athletic trainers associated with all the high schools. I know that in the more affluent suburbs, this is a constant. But when you get to the urban schools, they don't have the funds to have their own athletic trainers. And I think it's key to have trained personnel there at all times for the practices and everything. So I hope that we get more in terms of that legislation.
Indeed.
And then
I completely agree with that. Just to interject there quickly, is just as a physical therapist, we 1000% need athletic trainers at every sporting event. And I know that's not realistic for many in the short term, but in the long term, I think if you're putting in $500+ for your kids' jerseys for a season, a $25 fund per parent, I think is totally appropriate to get an athletic trainer on the sidelines.
Yep. And then, the other stuff I hope to see is that some of the emotional hype associated with all this calm down a little bit and being able to step back and look and see where we are with the science. And again, with things like CTE, with prolonged post-concussion syndrome, these are things where I think we still have a lot to learn, and let's wait and see what the findings from the research studies show before we go on a case-by-case basis and get everybody riled up from every case that comes in.
Yeah, 1000%, Bill. And if I could give you a high five, a chest bump, and all the things, I mean, really though, I mean, just spot on there. And one of the key talking points is, we have to know what we're looking at so we know what we're looking for. And as someone who's a survivor of post-concussive syndrome and things like that, we have to make sure, hey, did we rule out everything? Are we looking at chronic pain? Are we looking at the cervical spine? Or do we make sure we ruled out ocular, motor, vestibular, any pre-morbid, mood issues and things like that. Again, we've got so much to learn, and I think it's those folks like yourself out there that are really so well versed in the injury and the science, quite frankly, that you're able to say, I don't know, but hey, let me do the research to find out. So I really appreciate your service that you've really put into this field of concussion.
Well, thanks. Yeah, no, it's been tough at times, but what can I say? I think it needs to be done the right way, and hopefully we've been on that track. I've had some wonderful collaborators and been parts of some great research teams, and I hope we can continue with that.
Indeed, and in the spirit of Olympics, as we close up shop here, can our listeners expect anything that's coming down the pipe for, or I should say, half pipe with the Olympics going on for publication that you're proud of, and that's going to be coming out in the next few months?
No, lately I've been doing more reviews of things of where we stand with the CTE studies. I'm part of Bob Stern's a large diagnosed CTE project to develop the criteria for diagnosing CTE in living subjects. I think a lot of exciting stuff's going to come from that study. And then I'm working with with Mike McRae and colleagues and some of his studies, that he has parallel studies going on with the NCAA DOD study on concussion, a smaller study looking at some of the same biomarkers. So I think important things are coming from all those studies.
Indeed, and just exciting to see. Again, I know that the research that's out there for you guys listening in, I know it's like a fire hose, and I know it's hard to break down, but I hope you lean in and pay attention to the names that are on this podcast, like Bill Barr, because, again, you guys can learn so much from his work that he's put in throughout the decades, not years, and what's going to be coming out down the pipe for him. So, Bill, if people want to reach out to you, what's the best way for folks to kind of say howdy and find you out there in this world of social media?
Well, one is Twitter. That I've been active in Twitter, and people can contact me through there. I also have a website up at NYU-Langone Medical Center where I work, and there's a website there and with contact information.
Awesome. All right, and for folks that are listening in, his Twitter handle is at WB, like William Barr _Barr, at WB _Barr. Well, Bill, thanks so much for coming on to Concussion Corner. I hope we have you on in the future as well.
Great, my pleasure. Thanks for having me.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.